Right, good morning, everybody. My name is Bob Fryatt. I'm the project director for the Health Finance and Governance project based in Abt Associates. And I'd like to welcome you to this session about strengthening the front lines of care, governance and accountability for strong health systems. So I hope we have managed to get some coffee and tea that's out the back if you'd like to have some more. So we're here because there's a growing recognition globally in all countries, low, middle and high income countries, about the importance of community health systems. It's critical to expanding healthcare and achieving universal health coverage. I've been asked to start with what do we mean by community health, clarifying what do we mean by community health systems. And at the conference last year in March, which I'm sure many of you were at, on institutionalizing community health that's based in Johannesburg, our colleague Stefan Peterson from UNICEF defined community health systems as having three legs and many parts. The first leg being around the frontline health workers themselves, the health system that's actually embedded in the community, and also the links between that community health system and the broader public healthcare system, which has obviously many functions, including responding to disease outbreaks and responding to emergencies. And it's 8 years today that that was so important during the dreadful Haiti earthquake that happened. So we'd like to continue that dialogue that's been going on for some years. We want to keep the profile and raise the profile and the importance of this discussion. And so we're very glad to have some very distinguished and important speakers here today. And we want to talk about particularly around some of the governance challenges of community health systems to make them effective. And to kick things off, I'd like to ask Tim Evans, who's the Senior Director for Health, Nutrition and Population, to come up.
I have just a few remarks, and I want to begin, though, just with the obvious thing for a group here that community health systems matter, and they matter both for the good and for the bad. And let me just give two examples from when I was living and working in Bangladesh. The first is the revealed or tacit innovation that takes place when smart people who understand their context are solving problems, which the broader system is often insensitive to. And a great example in Bangladesh was, some vaccinators who were working in the community realized that a lot of women were forgetting to bring their children back for second and third vaccinations. And so what they did is they wrote the woman's cell phone number on the vaccination sheet and sent text reminders. And all of a sudden, DTP3 coverage went up from a relatively good value in Bangladesh, somewhere around 80%, to over 90%. There was sort of a 11% increase in vaccine coverage, in part because what happened was just on this common sense, smart thing to do, initiated by a community health worker, it went viral on its own. There was never any policy. There was never any big conference in Alma Ata. People are smart. They pick up things if they work. And I think there's a lot of that sort of innovation that takes place every day. And I think for those of us who sit at 35,000 feet, we risk being too blind to it and therefore missing out enormous opportunity to do better, recognizing that there's a lot of intelligence in the system at the peripheral level. The second example is on the not so good side, is when I was looking and chatting with a community health worker and Shasta Shebika is the Brax health worker who was linking up with a woman who was 7 months pregnant. And I was asking her, well, where are you going to deliver? And she said, well, at home. And I said, great. And with whom? And I was fully expecting her to say, well, with my skilled birth attendant, community skilled birth attendant. And she said, no, with my pharmacist. And I said, what? And she said, yeah, the pharmacist who's in the village, he comes and to my house. And I said, well, what does he do? And she said, well, he puts in the intravenous, and then he gives me the fluids and the drugs. I said, oh, well, what drugs are given? And there was this interaction back and forth. And she said, they said oxytocin. Oh, really? I said, when is that given? Well, that's given really early to accelerate labor, to increase the strength of contractions. So I said, holy jumping. I'm not an obstetrician, but a tocolytic in the first stage of labor risks a couple of very dangerous things, which is deprivation of oxygen to the fetus, number one, and potential problems with the uterus in terms of rupture. And I was saying, this practice is going on. It's not documented. It's demand-driven. It's supply-driven. It's not expensive. I looked at the intravenous that was being used, which was shown to me by the pharmacist, a lovely little butterfly valve, 10-gauge, very nice state-of-the-art type of thing. So it looked like good antiseptic technique was being used. But this was going on all over Bangladesh as far as I was concerned. I'm a big one on extrapolating on N of 1 studies. But I say this because this might be a behavior that one might want to investigate, measure, and in some way reform, because it may have and probably does have negative consequences. So I think this frontline issue is very important. And of course, we saw in the context of Southern Guinea and the outbreak of Ebola, it was over 3 months before the first case of Ebola was detected. And it's very clear that had there been a good community health presence in Southern Guinea in December of 2013, and beyond that village, that there would have been a much earlier pickup of that outbreak instead of when we got it 3 months, which was, say, too late. So the other part of this is that this isn't sort of the nice romantic 1978 vision that we should have self-sustained health in villages everywhere. This is the reality that our global health security is dependent on a meaningful translation of universal health coverage such that there is real coverage with bona fide trained workers, presence of the health system that is within reach of every population. So those just by way of introduction, because sometimes examples take us away from over-theorizing things. And governance is a classic area where we can get lost in theories of governance and various things. And that's not in any way to dismiss this. The stewardship role in the health system is absolutely fundamental, but it's a devil in terms of its complexity. And I just want to make a couple of comments on it, and that the health system in general faces a set of very powerful but countervailing forces, centripetal and centrifugal. They're things that are pushing things to the center: hospitalization, specialization, careers, money. And they're things that are pushing things to the periphery, which are patient demand, overall decentralization of the system, democratization, and also searching out of more markets. And these things operate at the same time, and they operate with a plurality of players. And so one of my favorite economists, the first woman to win the Nobel Prize in economics, Elinor Ostrom, she and her husband in the 1950s developed a theory of polycentrism. And it basically was a recognition that if you look at social change in any context, it's rarely that the government leads it and manages it fully or is accountable for most of what changes. Rather, there are agents of change, multinodal change, which are relatively independent, which are in fact the delta force of what makes systems change. So my first point related to the governance of the community health system is, if anyone thinks somehow that there's some centralized plan that will be centrally controlled and delivered, I think you're living in the wrong century. The reality of virtually every health system everywhere is they are increasingly pluralistic with multiple stakeholders, not all of whom see eye to eye. It's a negotiation. And so I think that governance reality of multiple stakeholders and how you negotiate some shared vision and shared buy-in to a bigger picture of where the system needs to move is absolutely fundamental if we're going to make community health systems resilient, robust, and high-performing. Beyond the multiple actors, there are the multiple sectors issue. And so it's not just the health sector. One of our biggest challenges when I was working in Dhaka, and something that my wife is currently working on full-time, is the issue of urban health. And in Bangladesh, urban health doesn't fall under the Ministry of Health, it's under the Ministry of Local Government. And try negotiating with the Ministry of Local Governments if you're a Ministry of Health. It's not an easy discussion because it's not a singular discussion. You get into municipal politics and different mayors and different divisions of localities. And then take that into a slum, where most of the organization of everything is informal and somewhat dangerous when you look at the mafias and power struggles that characterize those environments. So we should open our eyes to those realities and say, that's what we're looking at. And the real question is, how do you then negotiate shared vision, common purpose, and space so that you're dealing with all of the key operators? Related to this, therefore, in building community health systems, I think, is the issue of participation. And this is a corollary of pluralism, that if you recognize and acknowledge multiple actors, then the development of policy has to be one which is engaging of those actors in some way, and engaging in a way which recognizes that not everybody will see eye to eye, and therefore managing vested interests and still coming up with some clear way forward is particularly important. I say that because sometimes the informal private sector or the formal private sector are seen as not part of the formal system, but as my examples suggested, or one of my examples suggested, I think you ignore them at our peril. I think moving on, that you've got to have accountability and governance around some sense of design. And I think the service delivery models that are inclusive of community health systems need much more work. And they need work not only because PHCPI, primary health care, is nearing 40 years. It's the conditions of '78 in the height of the Cold War era that were preeminent around Alma Ata, as it was called in 1978, and the Declaration on Primary Health Care, are not the ones we're currently living in. And they're not the ones geopolitically, they're not the ones socioeconomically, and they're not the ones in terms of what's driving change within the health system. So this set of exogenous, endogenous forces is one that we really need to redefine what Barbara Starfield identified as the 5 primary C's of primary health care, but how do those have real meaning in the context of models of service delivery? And although context is going to drive what happens anywhere, I'm a big believer that when we look across systems, that the challenges that you find related to contact and continuity and comprehensiveness are sufficiently similar that there's value added in comparative cross-contextual types of studies. So I think that there is real value in looking at performance of those frontline systems. And at the World Bank, we're trying, to, along with other partners, to measure performance of frontline systems through something called the Primary Healthcare Performance Initiative to really get a discipline in understanding what constitutes good performance across a number of the metrics that you would expect. One of the big bugbears and opportunities related to frontline systems relates to human resources. And we did some work for our president, who's a big advocate of community workers, a few years ago. And we did an inventory of bank projects and looked where the bank had supported frontline workers. And it was a real shocker for me, because you might think the World Bank has no interest in frontline workers, but I couldn't find a country that has a notable frontline worker program where the World Bank hasn't been involved. Brazil, the family health program and that massive transformation. Indonesia, human development workers, which is now in the pipeline. Lady health workers in Pakistan, community health extension workers in Ethiopia. I mean, the list goes on. And what we were failing and are failing to do as an institution is to synthesize that experience and systematize the knowledge, not on how you create community health worker programs, but how you sustain them. Because their financing in particular isn't straightforward. What are their career paths? Are they paid out of the public purse or not? And how are they effectively supervised? So these are a set of issues on the workforce which relate, I think, are extremely important related to the performance of the frontline systems. And I would just say one further point related to the workforce is the reality that workers are not there as assembly line personnel. They have a technical knowledge, but they have two other dimensions that define compassion and ingenuity in problem solving in health systems. They have values. And if you have a system that's really working towards universality and equity, those workers can be the manifestation of that on the front line. So values are incredibly important. And two is they are problem solvers. They're smart. The example of just noting the cell phone numbers on vaccination cards as an example, but recognizing that if they're given the latitude and freedom and incur incentives to innovate and draw on that ingenuity either individually or collectively, then there's a tremendous amount more that could come than somehow thinking that it all has to be derived from the center. So this, as the bank has been pushing results-based financing over the last 7 or 8 years, one of the lessons that we've learned is not so much that the financial incentives change behavior. In fact, when you look at theories of incentive, as our chief economist Paul Romer has, we find an inverse relationship between the degree to which a system changes and the size of the incentive. Smaller incentives create bigger change. Very counterintuitive, but behaviorally, there are lots of reasons for that. But what I'm suggesting in this context is that we really need to look at, and this was one of the lessons of RBF, is that the de facto decentralization, the greater autonomy provided to local units of delivery, allowed them to negotiate and navigate better performance than could ever been hoped for if we felt that some top-down solution was going to emerge out of a rabbit's hat in some capital or in Washington, D.C. So with that, I'll finish here, and I'm happy to take any questions on whatever I've said or whatever I haven't said. Thanks.
Tim, thanks very much. That was tremendous, as always. I have a couple of questions, but anyone who would like to raise any questions first of all to Tim about that?
Recognizing that I have 15 seconds.
I'm going to kick off whilst you're thinking. Tim, love those first examples. I'm very interested in your Bangladesh example where you met that lady who was planning to be with her pharmacist. So when you took that back, assuming that happens across the whole of Bangladesh, that sort of action, when you took that back to discuss with your colleagues and the policymakers and such like, where were the solutions around that? If the quality of care and governance of quality of care is so key, what did that lead to as regards to response to so that could change in the future, those behaviours wouldn't be there in the future?
So 3 things, Bob. First, the response wasn't sufficient. We probably didn't catalyze enough recognition and attention to this. It remained one of those field visits which was personally enriching but not systems changing. And I think we've all been on those sorts of visits where you learn a lot, but we fail to translate and communicate sufficiently to get more things. So that's number 1, and that's a personal admission. Number 2, I think we have to study some of these things much more systematically. It may have been that I saw an outlier and things. So, and I did discuss this with some of the folks at ICDDRB, where BRAC has a very intimate relationship, and there was a lot of interest. I'm not sure whether that's translated into a systematic study, but I do think there's value in saying, well, how can we pay more attention to studying some of the unintended consequences or unintended or revealed behaviors of systems at the front line. And that has both positive and perhaps corrective opportunities. And last thing I would say on this is in the context of governance, the informal providers, pharmacists, have often been seen as money-grubbing, poorly educated tyrants from the sort of the formal health sector perspective. And when you sit down and chat with them, they're as enlightened and capable as anyone in this room. And a lot of them have read and are online and are connected, and therefore they are a potential latent resource that can be tapped. And rather than close your eyes and pretend that somehow they're going to disappear, engage and work with them. And I heard, again, through my better half in December, who's a little bit more connected with the field than I am, that there is now an effort in Bangladesh to certify the pharmacies, and it's really an effort to recognize them more formally as part of the health system, but as part of that, make sure that areas where you think standards are particularly important in terms of prescription practice and indications for using certain drugs, that there's better behavior across the system. So I'm not sure how far that is in terms of implementation, but I had a clear signal that there's something moving on that front. So I think that's also an important part. And it relates, sorry to go on, but I think it relates to this issue that health systems have these 2 countervailing forces. Part of what's going to help community health systems work better is a strong stewardship related to an expectation for care and an ability to effectively enforce and get those standards across the entire system. That does require some strong central governance. You can't simply have this be figured out at every decentralized unit. So I think that's another point, is that there's a co-dependence of having strong governance locally, but also centrally.
Tim, thanks very much. Any other comments? Please. You'd like to say who you are and your affiliation with your organisation, if that's okay.
My name is Li Yang. Thank you. My name is Li Yang. Just wonder if you can give us more information about how much demand or how much supply of healthcare professionals And are they all private sector by their own hiring, or is it really by a global organization, volunteers or something on this sort? Exactly how much is for private sector and how much is for world organizations? And exactly how much is the cost of the health care and how much they pay by individuals or how much they pay for the insurance or World Health Organizations? Is it free or what?
Great. Well, if I understand your question, I think there's no simple answer. There's a lot of different practices with respect to how frontline health workers are trained and employed, remunerated, and supervised. And I think one of the things we need to do is to look more systematically at the different ways of doing that. We deal at the World Bank a lot with ministers of finance, and when you come to them with a proposal of adding even one extra health worker to the rolls, it then invokes discussions with ministers of planning and development and the structure and shape of the civil service, which usually takes somewhere between 1 and 10 years to get a decision, meaning that bureaucracies are very cautious about decisions on bringing on new workers of any type, education, etc., onto the public sector roles. So I think it's very important for us not to make an assumption that this is something that can be done through government structures. This is especially important when you look at the structure of financing in quite a number of low-income countries where upwards of 80 to 90% of the total health expenditure is on the workforce. And when you remove that and say what's left, then you have very little room for maneuver in terms of how you're going to address priorities or shift resources to reflect new needs. And so I think both of these points, I'm suggesting that we need to be much more open our eyes to where the private sector is engaged. And when I say private sector, I'm saying non-state sector. So a lot of NGOs are on the front lines and really pioneering a lot of the training and deployment of community health workers, but also increasingly the private sector, especially when it comes to training. I did a study when I was in Asia across 5 countries, including India and China, and what we found is that most of the growth in the training of formal health workers in terms of new institutions is taking place in the private sector. So public sector institutions are perhaps by design or default very slow to change, grow, or expand when it comes to training. Private sector entries we're seeing all over the place, all over the world now, and becoming much more aggressive in seeing opportunities in training of health workers of all stripes and sizes and kinds. And so I think this is an area where we need to open our eyes and look at how to work with that much more fundamentally to make sure the sorts of workers, the qualities, the places we need workers, that we're shaping or nudging market forces in that direction.
I'm Jean-Jacques Frère from the Asia Bureau of USAID. Just one quick point. You have discussed about the financing, how to integrate the community health workers into the formal health workers and how the formal health workforce and how long and complicated it would take. But this is sometimes an acute problem. I mean, I won't talk about Bangladesh, but I was just back from a country that has accessed lower and middle income status, which means that donor funding is getting significantly decreased, and that comes from bilateral and that comes from the Global Fund and major actors. As a result, and I think we've worked with some Abt people on that, and how do we ensure that what had been donor-supported with an excessive degree of dependency can be transitioned rapidly. We're talking, and we were working on HIV/AIDS and TB, where there was a lot of very active role from the community health workers. And all of a sudden, I mean, those who were funding, and I'm talking about our own agency, but also about the Global Fund, I don't think the bank, or maybe the bank was involved as well. This is going to be phased out within the next 12 months. So that's a very practical issue. The other point that I'd like to make is that we as donors have also contributed, because we supported them, to the creation of so many types of community health workers. It's not unusual. And I was thinking about a country in the Caribbean, in fact, Haiti, where you end up having community health workers for vaccination, others for family planning, then a third group for HIV/AIDS and TB, and then you have the water and sanitation community health workers. And that's really not sustainable, and that creates more chaos than anything. And I think this needs to be looked at as well. We need to formalize what we expect from the community health workers.
Thanks, great points. Tim, do you want to?
Yeah,
react?
very quickly. And Jean-Jacques, thanks. You failed to mention that you have a very strong association with the World Bank. So you're guilty as charged. You're now redeemed because you're working with a credible agency. But in terms of the question, it's an excellent one. And just a couple of thoughts. First is on financing. Yes, 21st century financing, or this decade on the financing for development agenda that was agreed by the UN in Ethiopia, has us into a new era where the premium on domestic resources is going to grow. We issued a global monitoring report on universal health coverage in Tokyo in December. And in that report, we identified that out-of-pocket payments that exceed 10% of a household's income as a form of financing healthcare are growing. And they're growing at somewhere between somewhere around 5% per year. So 800 million people in households around the world are spending more than 10% of their income on health. That's called catastrophic health expenditure, and that's the SDG target 2 under 3.8.2. When you aggregate that across all low-income countries, that represents $500 billion per year, 500 billion. Now, how much was spent on ODA last year in health? Come on, this is a development audience. Yeah, about 30 billion. Okay, now when you look at 30 billion versus 500 billion, which number is larger? Right? So that's wasted domestic resource by and large, right? Because we know that the most inequitable and inefficient way of financing a system is to pay when you're ill. Because when you pay for when you're ill, there's no way to plan, and there's no way to pool, and there's no way to cross-subsidize. And so all you have is whatever people show up with, and often it's what the rich can pay and not what is needed for the population as a whole. So we need to look in a very major way of how to crowd that financing into prepayment systems, and that begins at the community, because that pharmacist helping that woman with her pregnancy was not free of charge. That woman was paying out of pocket. Right? So one is to really look at that, and recognizing this, the importance of domestic resource mobilization and the legacy of neglect that we in the development sector have had, particularly in health, of not focusing on priming the pump for domestic resources, building those institutions, and having conditions related to growing health sector budgets. We created the Global Financing Facility in 2014. And it has very explicitly as part of its DNA an effort to work with ministries of finance and grow the health budget, both so it's smarter, it's scaled, and it's sustainable, right? So Ali is going to talk a little bit more about that in a second, but I think we really need to think about it. And the workforce then needs to be considered as part of that. And the financing of the workforce, particularly when it comes to training, is often not the exclusive purview of the health sector. You get into health education, the education sector. Two other points very quickly. First, career paths. When you're thinking about how to finance and retain and sustain and grow the health workforce, what's happened in Ethiopia with the second phase of the community health extension workers, whereby experience for 5 years, further training, and over a 15-year period, some of these individuals move forward to university degree qualified nurses or paramedics. And I think this is a huge opportunity, is to see them not simply as volunteers who will leave quickly because they're all ambitious, but actually set up situations whereby with good work, they get opportunities to access training and move on and move forward in their careers. And recognizing as well, the health sector is a wonderful employer. It employs more people increasingly relative to other sectors, and often with a good gender balance. Lastly, research on delivery systems in terms of the efficiency issue. TDR, the Special Program of Tropical Disease Research, did some fantastic research now maybe 10 years ago in which they addressed this issue. The onchocerciasis workers were working alongside the TB DOTS workers, who were working alongside the vitamin A supplementation workers, and these villagers were being retailed left, right, and center by the bicycles, this hat, this T-shirt. I say, hold on, guys. You know, these guys can multitask. And so they brought it together, but they studied it. And they realized they could get more effective delivery, better coverage, by organizing integrated systems of community delivery. And that's published somewhere in some reputable journal like Lancet or something. But so I would encourage us also to think then there are these efficiencies related to integration which defy a simple rhetoric that we'll all hold hands and do things together, but benefit from some disciplined analysis on how some dimensions of what constitutes key vectors of care can come together.
So I'd like to invite up David Hipgrave, Ali Subandro, and Joy Tag up to the front if they may. David is the Senior Health Advisor and Team Leader on Health System Strengthening in UNICEF. Ali, you just heard, is the Nutrition Specialist working on the Global Financing Facility in the World Bank. And Joe Tag is the Senior Private Sector Financing Advisor for USAID in Washington. And I'd like to ask David to kick off and just to say thanks, David, for coming along. It's actually a conversation with David following the Vancouver conference that led to this event. So nice to see you here. And David, to give the UNICEF perspective.
Thanks very much, Bob, and thanks to Abt and whoever else, whichever other organisations were involved in this event. It's a pleasure to come down from New York to Washington, and a pleasure to see so many people here. Is my microphone on? Can people hear? Okay. So in 2016, UNICEF launched a new strategy for health with an appended HSS approach, Health System Strengthening approach, which focused very much on the community as a key delivery entry point for UNICEF's programs and obviously for UNICEF's mandated constituency, which is the world's children, particularly in low and middle income countries. We are now working as much as we can to disseminate that message, not only through our country offices, also to partners, and are happy to have the opportunity to do that today. But I will say that focus, it's not new obviously, but it's also founded on some very good work that WHO has done. And I have taken the liberty of having 4 slides. So if the first one could go up, it's not very easy to read, but The work that WHO has done on people-centred health systems, I think, is worth highlighting, because it does mention a number of the things that Tim's already spoken about this morning, and it summarises very well a number of the key things which a panel on effective governance and community health systems should focus on. So just to read from the preamble of that strategy document, which was released in 2015, people-centred health services are an approach to care that consciously adopts the perspectives of individuals, families and communities, sees them as participants as well as beneficiaries of trusted health systems that respond to their needs and preferences in humane and holistic ways. It requires that people have education and support they need to make decisions and participate in their own care. It's organised around their health needs and expectations rather than diseases, facilities or providers. And it also underlines the importance of integrated services at different levels and for different types of care. So it emphasises 5 elements or strategies, which are some of the things we've heard about already this morning: empowerment and engaging people and communities, strengthening governance and accountability, and particularly participatory governance and accountability to the beneficiaries, that is communities and individuals, coordinating services, including across sectors, reorienting the model of healthcare, focusing on outpatient care, primary care, prevention and promotion, a life course approach, and new technologies and information and communication technologies in particular. And finally, creating an enabling environment for each of the preceding 4 areas, in areas like leadership, quality, and the organisational culture of the health sector. And it also mentions a life course approach, which is very important for UNICEF in an increasing number of areas, including NCD prevention through interventions that apply before pregnancy, throughout pregnancy, and throughout early childhood and into adolescence, and going the full circle around. So these things are obviously all very important to UNICEF's concept of community health care. And I might just ask for the second slide to be put up. Next slide, if possible. So this is a model of community health that it's not mantra. It's not something that we expect all our country officers to adhere to, but it's something to basically draw people's attention to the different elements of what a community health system involves. With the community health worker or the kinds of people that Tim said, the bank and others, and our USAID colleague alluded to the problem of having created multiple different cadres of community health personnel. So it's one person in the middle there, but it could be a number of different people representing community health services. With on the left side, the kind of accountability and governance environment within which those workers function. And on the right side, the kind of clinical services which also support their function at community level. And across the top are all the different elements which enable a functioning community health system. And these are essentially the building blocks that you've heard about for so many years, really since 2007, expanded to include some more specific things which are part of those building blocks. So things like governance, financing, data, HMIS, of course, payment mechanisms, social accountability, private sector engagement, etc. And we've already heard that the importance of, in particular, governance, which this panel is to be discussing, including decentralised governance, because it can't be top-down, it also has to be a bottom-up, the governance obviously has to be a bottom-up issue as well. So I wanted to just run through some examples of work that UNICEF's been involved in, not as the sole agency, but obviously often and usually in partnership with other agencies, and perhaps some of your agencies, some of the people representing agencies in this room have been involved in some of these. So the first one is a project called Social Accountability for Every Woman, Every Child. It was funded by the Gates Foundation in the context of the Promise Renewed initiative, which we and USAID and others have been involved in. And since 2015, this is a project which has funded initiatives at country level in, I think it's 6 countries. Actually, I've got the list of countries. Kosovo, South Africa, Mozambique, Guatemala, Western Central Africa generically, and Nepal. And each UNICEF country office was invited to submit a proposal. There were 65 proposals, so it was well subscribed to. And they were invited to come up with initiatives which focused or which improved social accountability and engaged communities in issues to do with maternal, newborn and child health as part of the Every Woman, Every Child initiative. And I won't go through what each of the individual country projects undertook, but they had in common a sort of a new technology, radio, social media, television, radio and television obviously not new technology, but engaging the communities through these mass media initiatives to be more aware of and to participate more in MNCH services and to, as was alluded to earlier this morning, be part of the development of and the implementation of and the governance and management and obviously community participation of those services. So those projects are now, those activities are now in train, and I hope we will see some reporting on those in the next 12 to 18 months. The second initiative is something called Rapid Pro, which again many of you may have heard of. It's an SMS technology, an app, which is very easy to set up locally. It doesn't require, it's an Android-based system, but it doesn't require any major IT skill to set it up and contextualized locally. And it can be, it's been used for us in MNCH, but it could easily be used for example, DOTS follow-up or other health initiatives. And I think it could easily be used for contacting farmers and engaging people in the agriculture sector to follow up on what they're doing. And it's basically communicating with large numbers of individuals through SMS technology with a template set of questions and requests for answers, and then the aggregation of data acquired through that methodology so that information on behaviour, on engagement, on two-way communication, etc., can be undertaken. And so there's an example that I've got called Mama Namwana, which is focusing on improving maternal and neonatal health services in Tanzania. And I've got a couple of other examples of that in Ghana and Rwanda as well. So that's just another example of communication with individuals and how technology can be used to improve the engagement of and therefore the governance. I will say that there has been an attempted real-time evaluation of Rapid Pro by a group of academics in Rwanda, and they looked at improvement of service uptake and quality of engagement, or at least the engagement of individuals, in this case mothers for maternal health initiatives in Rwanda. And it said that individually that Rapid Pro approach and the SMS reminders, that mHealth approach, was not effective unless there were concurrent improvements to the services. So you can't expect these kinds of new technologies to work without having good service provision at the same time. So a couple of other examples quickly before I finish. There's another mHealth approach called U-Report, which UNICEF has been promoting actually for about 8 years now in a number of countries. And it's a free SMS service designed to, again, communicate in a two-way fashion with community-based informants. And it basically recruits people at community level to report on the conduct of health services, and it might be the presence of the health worker, whether people felt like they were well treated, whether drugs were in stock, whether the EPI program was happening as it was scheduled to, whether the antenatal clinic did this, that or the other intervention as part of that service. And so again, that can produce large amounts of data from community level, which can be a rapid appraisal of the function of health services. A couple of other things that we're involved in is in partnership with the University of Oslo and a number of other partners on the introduction of DHIS2, which is district health information systems using administrative data and getting data all the way from community level. It's then and at district level, it's then collated and fed up to national level. And it enables the very rapid development of scorecards or dashboards. Could I have the third slide? Sorry, this one was on the Rapid Pro. I forgot to put that up, but it's basically where the different SMS messaging goes through in the MNCH lifecycle. So next slide. So this is the kind of scorecard. Obviously, this is quite old, back from 2014, but you can't read the fine print. But down the left side is the districts in Tanzania, and across the top are the different MNCH interventions, and red is bad and green is good. This can be updated quite quickly, so you can see some of the cells are yellow and red, and it's kind of indicating that things are in progress of improvement, or green, or yellow and green. And again, so across the top, there's a number of different MNCH interventions which are tracked using real-time community-based data, and that can be used very rapidly for evidence-based planning, accountability monitoring, and obviously for governance of things down all the way to community level. And finally, I know that public financial management was one of the other topics that we were asked to consider in this morning's panel. And we are in a sort of new initiative in partnership, hopefully with the bank and USAID. We're having discussions with those. And we're conscious of the fact that PFM is often top down through public expenditure tracking surveys or very detailed analyses of where the money flows, without much focus on how PFM issues can be important in community-based service provision. And so we're in the process of piloting a tool to look at a bottom-up assessment of public financial management and how the availability of funds or resources influences, for example, drug availability, health worker participation, and the actual management and provision of services at community level. So those are 5 examples of things that we're involved in with a governance and community health sort of theme. Just going back to emphasising that these are things which are being considered more broadly by WHO and others in the context of acknowledging that, as Tim said earlier, there's a big focus on community health, and that's where we expect to be focusing very strongly for the next few years. Thanks very much.
David, thank you. Excellent. It's great to hear about those programs around integration, mHealth and PFM. We are, after the 3 speakers, we will have some questions. So please hold your questions. There's lots in there that's presented, and maybe we could drill down in the question and answer session afterwards. So next, I'd like to ask Ali Subando from the World Bank to make some comments. And as I said earlier on, nutrition and the Global Financing Facility is your area of focus. So perhaps you could say a little bit more about that, and particularly with this angle on community health service systems and governance. So Ali, over to you.
Okay, thank you. Thank you for the opportunity. I think I will get to that nutrition point, but I think I'm also going to talk about the CSO part, because I think that's also related to this. So I'm not sure how much of you know about GFF, but I'm just going to be quite brief about it, right? So GFF is basically kind of a financing partnership that support the government-led efforts to achieve this this goal for the. I mean, there was a launch in 2015 on the strategy for every woman and every child. So GFF is kind of the financing facility. So there's a couple of principles in GFF, right? So we're very much like results focused, and then also so basically for each country that receives GFF funding, we're asked them to develop what we call the investment case. So the investment case itself, I mean, again, to be consistent with GFF principle that we definitely don't want to create like a parallel system, right? So this investment case can be built on what is the existing already in the government program. So there's several, so we don't prescribe sort of a certain way of investment, a certain format of investment case. So in some country, it can be kind of a new policy that was being developed, and then we make it into investment case. Some is just kind of like an annex or a chapter of already an existing national policy. But I think what we have a couple of sort of kind of certain sort of like a minimum, almost a minimum standard of this investment case, that first it has to be centered on a clear set of results. So again, in line with the philosophy of GFF, it's very results focused. And then it has to be very well, has to be very well prioritized. Because I think sometimes if you see in this national policy, it's kind of become a very broad kind of like a laundry list of things. So we basically want this to be a prioritized based on the evidence at the local as well as the global. But then also we want to make sure that those set of intervention, the highly prioritized intervention, is actually linked to the financing strategy, because that's also sometimes what we see in this policy. You have all the intervention that they want to do, but there is no really clear like strategy how it is going to be financed. So another big area in the GFF is really supporting the government for this health financing reform, right? So basically focusing on improving the efficiency of domestic resources, because sometimes the government, or let's say they already have spending on a budget, but then if you look at it, there is actually room for improving the efficiency. And we're also working, of course, with the government to increase the volume. Again, it varies by country, but for I say in some countries when they're working on the syntax, for example, so we're making sure that syntax, a part of it will be allocated for the health spending. So, and I think that investment case is really focused on the how. And the last thing is also strong monitoring system. So basically, we just want to stop until the development of our investment case, but then really clear strategy of how you're going to monitor that, right? So as part of, and then the other feature of Global Funding Facility is what we call the country platform. So again, another principle of GFF is very much country driven. So the country platform is basically a set of multi-stakeholders from the government, development partners, but also CSOs. And this is kind of the entry point of what I'm going to talk about. The CSO has a very clear role there, both during the consultation process that leading to the development in terms of the prioritization of intervention. So, and as well as then once it's developed, then also in the monitoring, right? So because if we talk about CSO, it's actually kind of a wide range, right? You're talking about from professional association, service delivery or organization, and then sort of faith-based, so and then with that diverse profile of CSO, then I think there is a wide range of support that they can provide, right? So, for example, if we're one of CSO is in the research, then we can work with them on how to inform on the evidence base, right? But then with the CSO that works more on delivering service, because a lot of these countries they play quite a significant role in delivering service, especially in the marginalized area. So, okay. So then basically, just to kind of quickly then, because of that diverse profile of CSO, then there is really a lot of role in the process of GFF implementation. So I'm just going to quickly wrap up. It's just basically, sort of the key role in terms of the advocacy, so the mobilizing a resource. So we have a specific example in Uganda where they really lead the discussion with the government to make sure that the family planning is included in the investment case. They really work on that. And then the other thing is also on the monitoring, and this is very important because once it is done, we want them to be not only kind of standing from the outside, but really part of the monitoring system, meaning that if we have a joint annual monitoring report, then they're actively involved in making sure how these findings from the joint monitoring report are being resolved. Because CSO has this advantage of they have a strong presence on the ground, good connection with the community, but also at the national at this national level. And the last thing is about this elevating voices from the people that they serve, right? Because through the social accountability mechanism, they're really also playing and making sure that whatever that needs or priority that is identified in the local community are being translated upward in the process of investment case. So I think that's sort of, I think, the angle that I want to focus. And I think just last thing is because this is, I think, the part where the monitoring, accountability, and implementation, CSO is a very key role, because when you talk about community health system, you're actually talking both the integration to the primary healthcare as well how it's being embedded in the community system. And I think that last part is unfortunately not being, it's a bit of under studied, but that's really where the CSO could play a role, because, you know, I mean, in terms of how community getting involved in managing this community health workers, the accountability and things like that. So I think that's when kind of the CSO will play a key role as well.
Andy, thanks very much indeed. That was great. And well, again, in the questions, we might come back to talk a little bit more about the GFF role.
Yeah.
So thanks very much for that. Next, I'd like to come to Joe, who's working on the private sector in USAID. And Joe, over to you for your perspective. Thanks.
Good morning, everyone. My name is Joe Tayag. Thanks to Abt Associates for letting me come and sit on the panel. So I work with the USAID Sustainable Finance Initiative for HIV/AIDS within the Office of HIV/AIDS. And yes, I said HIV/AIDS like 3 times in that sentence. I focus on, but something that's not typically heard around the HIV space is I focused on mobilizing resources, one key word, private sector's contributions to the HIV epidemic. And I co-lead a team responsible for helping lower middle income countries to sustainably finance and administer community-based programs historically funded by the US government. There's a lot of key words in there, right? Lower middle income countries. These are not the Kenyas, Nigerias, Tanzanias of the program of the world that receive over $400 to $500 million. In aggregate, our 13 operating units within this country classification amounts to a total of about 200 million in general. So we're talking about Vietnam, Indonesia, Cambodia, the Dominican Republic, Thailand, and Ghana. These are also countries that are examples with have access active universal health coverage schemes. And these countries finance a growing majority of their epidemic control programs. So there's undergoing this state of financial transition as they grow economically. They're taking on greater ownership of the HIV programs. But USAID has supported to foster country ownership, and this is in large part due to our partnership with HFG and their technical leaders. Around this, we have cases where in Vietnam, PEPFAR has reduced our funding presence from 70 million in 2013 to 38 million as of 2019. But we've done that by helping to build the capacity for the social health insurance scheme of Vietnam to be able to take on the responsibility for financing ARVs and ensuring that HIV care is part of the empaneled network within that social health insurance scheme. Again, led by the leadership from HFG in the Dominican Republic, the government has increased their financing for ARVs from $0 in 2012 up to $13 million in 2016. And we did this by supporting public financial management around program-based budgeting, procurement, technical assistance, ensuring appropriate execution. That's all great for ARVs. You know, ARVs are a depoliticized kind of aspect of the health system as we think about greater ownership of HIV control. But I'd like to focus today on financing and governing HIV programs directed towards key populations. Loaded topic. In 2016, PEPFAR spent more than $115 million on key pops programming, and 1.8 million key pops were reached with prevention services. So key pops refer to men who have sex with men, injection drug users, sex workers, transgender people, and prisoners. According to UNAIDS, key pops and their sex partners represent 44% of all new infections globally. But when we consider regions outside of sub-Saharan Africa, including the regions that I'm specifically referring to today, key populations and their sex partners represent 80% of all new infections. However, there's a strong body of evidence that community-based key populations programming leads to better HIV service delivery results. Through community-supported case finding, we find positives faster. enhance peer outreach in civil society, supports initiation onto treatments much faster, and community-based adherent groups have been known to retain people on treatment, which helps to keep the virus suppressed. And if you ask anybody who belongs to these types of CSO or private sector roles how they have that success, they make their program sexy. In other words, they know their user and their participation and concerns within the health system and grow the program around that. But despite this evidence base, domestic programs have historically financed a minority of K-pop's programming. Even in Thailand, where you could argue that the country is actually pretty conducive to programming for K-pops, the domestic government finances 90% of their HIV program, but only 10% of their K-pop's programming. Why? So certainly stigma affects political will. Stigma affects political will. Stigma affects political will. You can't say that enough. And I think we have to consider in any aspect as part of the donor community and international community, how stigma has affected our own decisions and staffing and the way we deploy our programming for these countries. That's why it's easier for some programs to invest more in PMTCT, even though perhaps in that epidemic, there's less of an incidence among pregnant women. There's actually more of an incidence on key populations, but it's easier to talk about mothers than it is to think about needle exchange programs. But there are other technical aspects of governance that would facilitate for greater ownership of KP programs. I'm going to talk about 4 aspects today. Related to public financial management, regulations and standard operating procedures need to be in place to govern how community-based programs should be paid for their universal health coverage schemes. Let's stop saying the word engage when we think about communities. They are performing a public health service. They should get paid for their contributions to the health system. Let's take that seriously and in concrete terms. In Thailand, they are actually trying to mobilize about 200 million baht as of 2015 to be budgeted for community-based organizations to support hospitals to bring in and refer people to get tested. However, there was no standard operating procedure for a contractual payment between a hospital and a community-based organization. That 200 million baht didn't move for 2 years. And it was like, wait, you guys just need TA for contracting? We're more than happy to help you with that. Let's figure out how to cost, what that package should be, what should be reimbursed, how are we going to facilitate the managerial structures for payment from the CSOs. Let's get this done because you actually want to mobilize your resources. We need to help you to do that rather than just paying for our own community-based programs directly and kind of assuming a perpetual atmosphere of this. So we're focusing on trying to do that in Thailand, and we're hoping that with our PEPFAR incentive fund that we'll be able to mobilize resources from Thailand's National Health Security Office, their National Health Insurance Program, to be able to compensate for community-based activities. In terms of policies and regulations, just the basic concept to allow for things like community-based testing or lay testing to happen. Getting nods from our colleagues in Jamaica. This is a big deal. Community-based and lay testing facilitated by like peer networks can triple, quadruple, sometimes quadruple the yield in terms of finding positives. If they have such an integral and positive role for the epidemic, how do we allow that to happen in a safe and regulated way? And it's actually influenced and implicated in the national policy. We're also supporting policies that allow for the sale of pre-exposure prophylaxis in private sector outlets in Vietnam. Sometimes we forget that because they are vulnerable populations, that there are aspirational people within these groups. They may have the ability and willingness to pay in certain economies that actually has them feel safer going to a private outlet, paying for this prevention service and obtaining it. But we need to be able to include the private sector in order for that kind of dynamic to happen. It helps with financing prevention. It means that for USAID, we might have mobilized this facilitated technical assistance, but in the long term, if they're financing prevention on their own, isn't that a sustainable approach to development? In terms of data and information, USAID is working to develop data disaggregates by age and sex and K-pop's classification. A man who has sex with man is not a transgender person. There's aspect of identity that needs to be included in the way we monitor and think about data throughout the whole cascade and also the various outlets at which people receive care. A health clinic in a public sector facility is very different from the aspirational desires of a person wanting to go to a private sector tertiary facility. And I think we have to think about a participant's involvement in the health system and how they make their choices in order to truly develop programs that cater to key populations' needs. And community-based organizations have the clearest points of access for tapping into that type of desire. The private sector also has a role. We've seen programs in Southeast Asia and Central America partner with social media corporations like Facebook and Grindr to provide resources to men who have sex with men and refer them to safe testing sites. People are counseling on Facebook because there's this anonymity, there's this safety with groups because they've signed up for a Facebook group that's all about barebacking anal sex. Sorry if there's cringing in the audience for that, but we have to be able to talk in the same terms that community members speak of when we're trying to access them and guide them into services. And these partnerships with these large corporations like Facebook and Grindr actually facilitate that an authentic experience from the perspective of the key populations. USAID has also looked to private sector suppliers to shape markets among key populations. For example, through USAID technical assistance in Vietnam, we've quadrupled the sale of Key Pop's targeted condoms from about 4 to 5 million as of 2015 to now over 25 million, sorry, fivefold, we've increased it, over 25 million. That means that there's over 20 million more condoms that are now at guests' houses where commercial sex workers are employed. And then in terms of men who have sex with men, they have condoms that are now targeted at MSM clubs and other places that they frequent. So with declining donor resources, we have to consider how to break down the barriers to adequate domestic governance of Key Pop's programming that fully leverages the strength of community systems. We need to continue seeking solutions to remove institutionalized stigma associated with key populations programming to improve public financial management. We need to create an enabling policy environment, produce and use better data, and promote an inclusive vision of the private sector's role. We need solutions now, and I look forward to discussing these examples with you all today. Thank you.
Thank you, that was excellent. So just to quickly summarize, we've had some great examples from David and UNICEF's work around integration within community health systems, along the continuum of care, the use of mHealth, and bottom-up looking at public financial management. We've heard from Ali in the World Bank about opportunities arising for the relatively new global financing facility in countries that are engaging more and more civil society and the community health groups. And then lastly, Joe's brought us back down to ground with a real live problem in communities around key populations and the problems around stigma and responding to the needs of men who have sex with men, IV drug users and commercial sex workers and other key populations. So now we'd like to have a few questions. There's a lot that we've covered, but we can now drill down in a few areas. So anyone who would like to sort of kick things off? The questions to the panel, please. And again, if you could just say who you are again, that'd be great.
Thank you. My name is Li Yang. Thanks for your presentation. For each of you, you may consider my questions. First is I want to know your measurement of accountability. And then, so based on that, I want to know what kind of measure that you have, whether you are based on data, whether the data is correct or not, and how do you verify the data? I don't mean just who put a number in there, then you analyze from there. I want you to know how do you verify the number in there makes some sense, or the number is really corrupted number, or it really doesn't make real sense. And how do you improve your health care? How do you improve really the well-being of the patients or their family? And how much burden they need? I just wonder how much employment or the sickness, loss of the work days, if that's your measurement. And then you have a public-private partnership, I think World Bank and some NGO. I just wonder how do you measure the effectiveness of that? Because I know in America there are a lot of misdiagnosis. And they basically put the innocent patient there, and eventually they put them to death. So I just wonder if you can really consider not just by the number of dollars that people contribute or partnership, they put them all together. I just wonder how much they really produce a well-being for the patients or the society as a whole.
Thanks very much. Should we take a few other questions and then we'll come back to the panel if that's okay? At the back there. Oh, over there, sorry.
Yeah, hi. Tiernan Menon, Abt Associates. Thanks for the presentations. Wonderful. I had some thoughts, and maybe you can link kind of building on what Joe was presenting, which is basically domestic resource mobilization. Not all DRM is created equal. And so what are some of your lessons or reflections about the different types of DRM that can create results or in some ways even undermine health outcomes and create societal conditions which worsen health? And I'm thinking of regressive taxes, sales tax, even sin taxes, which can sometimes hurt the populations. I'm thinking of other forms of centralized domestic resource mobilization, such as resource extraction, that can actually displace large populations and worsen their health outcomes. So I'm curious what lessons you've had and whether you have any reflections on that.
Great. No.
Hi, my name is Naoko Kozuki from the International Rescue Committee, and we do a lot of community health programming, and all the various problems that have been raised are things that we're grappling with. And one thing I wanted to note from the previous talk and this talk as well is that all the examples are coming from stable contexts, when although this frontline workers, governance are all key issues for fragile and conflict-affected settings as well. And the message I'm getting is that perhaps the investment in frontline workers or the topic that we're discussing is not a priority for your organizations in fragile and conflict-affected settings. So perhaps you can speak a little bit more about how your organizations see your investments in those areas. And I very respectfully also request that you consider female representation on your panel next time.
Well, yeah, we're about the diversity. We have that coming. You can be reassured. So maybe some responses from the panel. Maybe we'll go back in reverse order. So Joe, you'd like to come up with some responses?
Yeah, and I think, Joe, in terms of the theme of accountability and monitoring, I think you're absolutely right that when we introduce a new stakeholder to helping to participate in the HIV cascade, we have to hold it to the same level of quality requirements that we would hold to any public sector partners. So in terms of clinical outcomes, which is a great measurement for the type of sustainable finance work we do, we measure their task within the cascade. If they're identifying positives, for example, then we measure their ability to actually find, among key populations who are actually positive. We measure how they are linked to care, and then over time, how well that they can keep people actively on their treatment. But we add an additional layer of that in terms of what are the controls and acceptable levels required when we assume a private sector partner. Will they pay for their own procurement of ARVs, or will we help set up a pool that helps to get negotiated discounts across the whole private sector so that they're completely sustainable and non-donor dependent? These are the questions that keep me up at night. Is overlaid on top of the health outcome results, we also have to think about what our appropriate strategy is within that space to do what Tiernan's talking about in terms of mobilizing resources in a effective and quick and yet long-term sustainable way that doesn't have any other negative repercussions in other areas of the health system. So I just want to echo, in terms of thinking about the measurement also for key populations, measuring their size is a huge ordeal, because measuring their size is a way for groups on the ground to say that we are important. If we need to be able to use the latest information and methodologies that we have, biobehavioral surveys, but also thinking about alternative approaches to measuring just how large and representative these populations are so that they're not so hidden. And then when we have that, that'll help serve as the denominator for our progress on how well they're delivered their services and how well we're serving them. In terms of avoiding bad DRM, so much of this is, yes, there's a policy and technical analysis part of it, of trying to assess what the various options and what the local country stakeholders have the political will of appetite to explore. But there's pressure testing that's super important to think about other implications. I think there is kind of this fallback where let's have a tax, and then well, you have to think about the tax incidence in the country, how many taxes there are already on sales, whether or not it's directed in the right way. So, beautiful example that is that came up in the Dominican Republic that no, we have not taken any action on yet, but we discovered from a USAID-funded analysis through HFG that there are actual guest houses which are oftentimes frequented by sex workers, and where you could kind of arguably triangulate there would be a site of infection. They're included as part of the formal sector, so they are taxable. They only have a 10% sales tax incidence on all their operations. Mind you, other sales tax and other corporations in the Dominican Republic have upwards to 25 to 30. So you're like, wait a minute, there's a potential way that we can think about ways to mobilize resources from the revenue generator that's most closely associated with the epidemic, that you could have a kind of political tie back to HIV. I think it's that kind of thinking. We're not necessarily moving forward with that, but it was like this thing that came up that we're only thinking about now of how do we start getting into the details rather than saying, let's have an airline tax, that's just not gonna fly in political will, particularly in countries that are already overburdened with high tax rates. So I think there's an incredible amount of creativity that needs to be involved. It does not necessarily have to be national. I think UNAIDS's work in terms of fast-track cities and thinking about resource mobilization from a city perspective, where the cities themselves might have a greater amount of political will and are more amenable to kind of progressively thinking about the status of MSM within their own community, because there are larger concentrations of them in urban settings. I think that there are spaces that we need to explore, but there's no clear guidance or handbook for how to do it. So we're hoping to gather more ideas from you guys, and we're certainly willing to consider what other opportunities we might need to fund greater innovation in this space.
Thanks so much. Ali, we still would like to talk about the fragile responses and fragile and conflict areas. That's something you're willing to talk about, and also the measurement and accountability, but over to you.
Okay, maybe let me start with the measurement first. Because I'm not very clear if I have enough sort of concrete response for the FCP, but for the measurements, I think as we explained, right, that GFF is very much results focused, right? So it's almost in all the countries that GFF is supporting, there is this element of results-based financing, right? So because we even pay for results. So definitely the component of like measurement and also verification that that data is correct. I mean, there is it's a part of the typical RBF process. There is sort of this quite like quite sort of like a rigorous process of how you're measuring the quality. So I think definitely the focus on measurement and data quality, because we kind of pay our we kind of disperse based on that achievement, right? I mean, and that based on the good quality of sort of like data that is being collected at the health facility as well as the community level. For the FCF, can you repeat the question? I just want to make sure. So are you asking about the different like strategy for the FCF for the fragile conflict?
Right. My concern was that basically, these issues apply to fragile and conflict-affected settings as well, in terms of the issues behind strengthening frontline workers, sustainability, cost, all those things. But all the examples that are given so far, not just here, but in many places, that the fragile and conflict-affected settings get looked over, despite the fact that they're very similar issues, just with harder solutions. So. Okay. I just wanted to get a sense for how your organizations are viewing fragile and conflict-affected settings. Is it that you are investing in it and it just hasn't come up today? Is it that you are not, because of various risks that are associated with investing in those places?
Okay. All right. I think
if you maybe say something, then David from UNICEF maybe can also
Yeah,
respond.
I'm just quickly on that. Again, just specifically, I'm giving example from the GFF. We are now working on 26 countries, right? So I think about 6 or 7 are FCF countries. In the countries like Haiti, and Afghanistan, for example. So we're also applying that results-based. And again, you would be surprised that actually in those countries, because of that incentive, that actually even data collection are actually going on, and we get like this data. So then even we can apply that results-based model in this FCF countries. So definitely it's also a growing focus in the GFF countries as well, and especially for the next, because we have 62 countries are going to be eligible for GFF. Thank you.
David.
Thanks, Bob. Yes, just to focus specifically on Naoko's question, I think if you could see this chart which shows the breakdown of UNICEF's overall program budget and the differentiation between fragile and conflict-affected or disaster-affected countries versus regular sort of development budget, you'd see that over the last 5 years or so, there's been a marked shift in the balance towards fragile and conflict settings. And a lot of that money actually goes to strengthening and making sure that communities are able to avail services, to have access to services. So it's definitely a high priority for us. One thing I think that underpins your question is the ability to work on systems and on sustainable impact in those kinds of communities. And I would say that it's a work in progress, not just for us, but for most organisations. And that especially in complex emergencies, that is those that have a human element, usually a conflict-associated element, that in those settings it becomes more difficult to work with central authorities, and in that case you often end up working a lot more with communities or local authorities because your likelihood of access and impact is much better than if you're working with central authorities who may not be popular with local authorities, etc. So we have huge programs in Syria and Yemen, particularly Yemen, I should say, and that's with as a primary support agency for the World Bank program there. There's discussion about programs in Libya. There's smaller programs in Iraq, very big programs in Afghanistan as well. So we're very much involved in service provision, and in Afghanistan specifically, where I spent 2 months, end of 2016, early 2017, there's a big focus on improving community access to services, even in areas that are actually, I probably should hesitate to use the word governed, but are under the control of the Taliban. We have activities going on with a community service focus. So it's a high priority for us, and as I said, an increasing area of our work. Just the one thing I would say in relation to the question from, I think it was Mr. Menon who asked the question. Privately, I'm not private here, but I often worry that the whole domestic resource mobilisation focus has a risk of being structural adjustment revisited, where the onus on raising funds will ultimately go back down to the individual. You don't hear any of the solutions that are discussed referring to that, which is good, but I think there is a risk that ultimately governments won't reallocate resources from defence or from transport or from infrastructure projects towards the health sector. And that's the kind of thing that we focus on in our Public Financing for Children initiative, which is quite a big program of our social policy team. And we have a framework for that which people are welcome to access, and I can provide if people are interested. But the area there is very much on advocacy for that kind of reallocation. And the other, I think, big area of focus, which isn't mentioned as much as things like sin taxes and airline taxes and things, is improved efficiency. And those of you who were at the UHC Financing Forum last year would recall that the focus of that forum was on efficiency and the huge gains that could be made in the health sector if public funds and also private funds were more efficiently utilised. Thanks.
Thanks very much, and thanks for those questions. I think we're going to move on, and thanks for raising those points, and particularly the point about the conflict zone. That was a great point to pick out, so thanks very much. So we'd like to a round of applause for our panel. Thank you very much. Thank you very much. I'd like to invite up Caroline Gomes, who's the Executive Director of the Caribbean Vulnerable Communities Association. I'd like to come up to the panel. Lisa Tarantino, who's a Principal Associate in the Health Finance and Governance Project based in Abt Associates. And Eric Sario, who's a Senior Health System Strengthening Advisor from Save the Children. And now we were already discussing some of the solutions, and not just the challenges, some of the solutions that's come up in the previous discussion, but this panel has particularly been asked to focus on some of the challenges and the innovative solutions to responding to the needs of community health and the community health systems. And I'd like to start to ask Caroline Gomes from Jamaica to kick off. Caroline, over to you.
Morning, everyone. It's been a pleasure to be here, and I'm really glad that it's warmer than it was last week, because coming from Jamaica, it would have been quite a shock to the system. I'm going to talk to you a bit about the Caribbean, because that's where we work and where I live and was born. And healthcare delivery in the Caribbean has long involved strong community participation. We've had for decades a focus on primary healthcare, and primary healthcare by its very nature involves community. But community engagement in the HIV response over the years has evolved. It's transitioning from family and community-led financial, emotional, technical support for people who were suffering, in quotes, having to drive their friends and family from hospital to hospital to try and get them a decent bed to die in, led to the development of support systems for people with HIV. And obviously this transitioned over time to delivery of services, trying to prevent it, prevention, testing, counseling, adherence counseling, peer support, advocacy, as well as addressing stigma and discrimination, which in our Caribbean setting is a huge challenge, and one that we still unfortunately have to put a large focus on. And there are basically two types of community systems in the Caribbean. One's geographic, a location where you have a strong community leadership and they're involved in trying to develop health systems relevant to their community, whether it be an underserved community or an uptown community. And then there are the key population-focused systems, which are based on communities of similar need, similar interest. And so we have now quite a few based sex worker serving community organizations. We have quite a number of strong MSM, LGBTI community serving organizations. We're even in the last few years developing trans community serving organizations, which is a real positive in a region where cross-dressing remains criminalized in some settings. And law is enforced. We have cases in the courts of people being charged for cross-dressing for nefarious purposes. But the development of these systems has been very uneven among the countries in which we work, CVC. And CVC actually works now in all the countries of the Caribbean, with the exception of Bahamas and Barbados, which are considered too wealthy for us to find any funding to work in. And they got greater or lesser buy-in from government health systems and national AIDS programs, depending on where you were. And they had remained focused on the prevention and the finding of cases. But there's a real need for strengthening both the community systems and the acceptance of the formal systems, of the contribution that these systems can make, and also to upgrade the thinking in terms of their role. They're not just organizations that can reach with information to people of similar sexual orientation, gender identity, sexual practices, but they're also able to provide all the other steps needed in the HIV response. So I wanted to talk to you a little bit today about a very successful model, but it's a one of about 3 or 4 that you can put your hand on and outline the success factors in the region. And the tasks of these community systems are evolving and changing. With the advent of the 90-90-90, we need to ensure that they are moving beyond preventing infection to identifying HIV individuals, getting them into treatment, and maintaining their adherence and care. And in each, while we are talked about as a region, sometimes stuck on the end of Latin America and the Caribbean, we are actually a set of disparate circumstances, and these need to be taken into account as you're designing and looking for lessons learned. But our services, community-based services, are critical for increasing the demand for the use of HIV treatment and prevention programs. In this acknowledged environment of high levels of stigma and discrimination, innovative service models are needed across the entire continuum of care. So I want to talk a bit more about an organization called Jamaica AIDS Support for Life, but I could have talked to you about VDH in Haiti. I could have talked to you about COIN in the Dominican Republic, where the Ministry of Health has formally integrated their services into the national response and support their provision of clinical services, and importantly, incorporating their data collection into the national system. So Jamaica AIDS Support for Life started in 1991 simply as a group of friends and allies trying to provide services to people who were infected and dying, stigmatized, ostracized, not even allowed into hospitals. And they evolved. They provided a hospice as their first service, which ran from 92 to 97, and then began responding across the broader spectrum. As we learned more, as we knew how to treat, as we knew how to care, they began taking on the job of offering these services. And today they offer them in 3 locations. In their Kingston head office, in a parish in Jamaica called St. Anne. Many of you have heard of Ocherius and Duns River Falls. That's one of our tourist meccas. It's not surprising, it's also one of the places where we have high HIV prevalence. And the other chapter is in St. James, which is the site of Montego Bay, our tourist city, and jumping off point for Negril, and Trelawney, and a number of other high tourist environments, which also, in our context, means high HIV prevalence rates. The Ministry of Health, as I said to you, has recognized the importance of JASL services. And JASL has become incorporated on all major HIV initiatives and committees in Jamaica. They're in the strategic planning process. They're on the country coordinating mechanism of the Global Fund. They're in virtually all of the technical working groups. They're on the monitoring, evaluation, and research group of the ministry. And they're there because they're providing services to the persons that the governments find difficult to engage and hard to reach, and sometimes even hard to see. And the importance of what they were doing became recognized because the government was failing on the parameters it needed to meet, even starting with the first 90. But JASL has built itself not only with government partnership, but also other partnerships, to do the work that it does so effectively, including the Planning Institute of Jamaica, the Ministry of Education, international development partners, including USAID, the UN, UNAIDS, Global Fund, and very importantly, a strong civil society forum made up of all the CSOs that are engaged in delivering HIV services in any way, which was founded with JASL and through CVC, and which functions as a coordinating mechanism to ensure civil society is providing coordinated, structured, and integrated responses to the duty bearers. Its treatment model takes into consideration the needs of the person, not their disease, not their vulnerability group, but their needs, with a special emphasis on key populations and clients with multiple complex needs, and takes a holistic approach because they respond with the provision not only of medical services, but social, mental, economic, and nutritional needs. They have a strong M&E application, they monitor for effectiveness, and adjustments are made as needed. And this promotes sustainability and diversification of funding. But this didn't happen overnight. Anybody who's worked in the CSO arena knows that there are a number of challenges that you're going to face to get to a position where you are integrated into the national response. And these start with questions on the legitimacy of CSOs. And I know I'm talking to the converted here, but certainly in the Caribbean, who are these people and what do they serve? And it's not a uniform across even the ministry in Jamaica that CSOs can effectively deliver services. And so we have questions as to, but can they contact trace? They're not trained in contact tracing. Really? Okay. There's mistrust from both sides and questions about the technical capacity of NGOs, power dynamics, and unfortunately, often tokenistic involvement. Now there's a shared vision and reporting mechanisms that include JASL. And so they are able to deliver their objectives, which include linkage to care, peer navigation, and they do this finding cases, peer navigation, in conjunction with smaller CSOs who have a focus on finding, reaching, testing, and linkage to care. They deliver retention to care and ART treatment, so they have a case management system, and they are actively promoting and achieving viral suppression with the provision of their clinical and support services. So just very quickly, 522 clients in care, of which 161 were newly diagnosed in 2016. 121 of those were linked to care, 43 of them linked by other CSOs. The Kingston Clinic, with the new service delivery model, moved from an 18% retention in care rate, the government rate is about 40%, to a 98% retention in care rate in 2016. And their viral suppression moved from 2% in 2014 to 40% in 2016. And they expect to see an improvement in that as they move forward. So, community delivery, important, effective, needs work, needs support. They're moving forward into a new phase now. They're working with us to support a system of monitoring of abuses and breaches of rights and health center delivery of services in order to have a shared database across the Caribbean that documents these abuses and helps to link clients who have not received what they thought they should receive to redress through official systems, Ministry of Health system for redress for client services, but also through targeted legal advocacy and taking of targeted cases.
I'm next going to ask Lisa to give some examples from the Abt perspective.
I'm going to talk to you about 3 different USAID-funded initiatives that are manifestations of the quest for improving quality, access, and responsiveness for healthcare. The first is at a global level. We have been working with the Joint Learning Network, which is a group of countries that are embarking on universal health coverage and are doing some cross-learning about their experiences. In 2015, in the context of one of their meetings, governing and improving quality of care was brought up as an issue that they felt was underemphasized in the pursuit of universal health coverage, and there was a concern that with financing reform that quality could be dropped, could fall through the cracks, and that it was a remaining challenge to be addressed. The USAID-funded Health Finance and Governance Project, together with the Global Assist Project, which is a quality project, worked with the Joint Learning Network, WHO, and the Institute for Healthcare Improvement to do some research on what are some emerging lessons, promising practices in governing for quality of care, and linking institutional arrangements, processes, and relationships to quality outcomes. This was through a literature review, qualitative interviews with, because sometimes things written on paper are not really how they work in practice, and through some joint learning events where we brought together policymakers from 13 countries plus international experts to discuss these issues. What emerged? Among many things, there was a consensus around what they called these 8 stones for governing qualities, which are a combination of key factors which these countries identified as potential success factors, and also areas where they felt more work needed to be done to improve. I'm not going to go through all of them, but I will mention one of them was political will. As Joe mentioned earlier, for anything you need to have some strong political will, developing a culture of quality, using data for measurement and improvement. But notably, one of these areas was institutionalizing non-state engagement, which institutionalizing working with communities as well as the private sector. And this was flagged, and it was somewhat a surprise to me, because a lot of times government officials will really just talk about accreditation, regulation, and that kind of thing. But what they found in talking about the really successful experiences they've had in improving quality, many of them included a component of early engagement with communities, early engagement with the private sector in policy development and then in implementation. But it does remain an area where they're challenged to find ways to make it work and to make it work. So following through on that work that we've done with these countries, there was a request that we develop a consensus statement, a global statement as a call to action for policymakers at the national level and also for development partners to focus on governance in the pursuit of quality care. And again, this theme, there were 4 areas. One was data for measurement and decision making. Indicators are always a challenge for quality. Cross-learning to begin to continue this way of sharing experiences, practical experiences and learning. Improving and strengthening policies and strategies. And lastly, institutionalizing community engagement. So, and I'm stressing the institutionalization here because I think we've all been involved, or we know of examples of these one-off or localized initiatives or donor-funded initiatives that don't really last or that don't get scaled up. But how can you make sure that it's a requirement that the community is engaged? Okay, so I'm going to talk about 2 concrete examples very quickly that Abt has been involved with, one through a health system strengthening project in Senegal, and another more mature example through Ethiopia's Health Finance Reform Project and Health Finance and Governance Project. I'll talk about the Ethiopia example first. It's a little bit more mature project, and it's a result of a national health finance reform initiative where through the course of health finance reform, a decision was made to allow for greater facility autonomy so that some fees that were charged to patients could be kept by the facilities and that the facilities would have an ability to decide where to invest those funds. And the idea is that it would be focused on quality improvement. And it comes to about 30% of their budget. And just in case I know people in the health sector worry about fees and the poor, the local districts finance the fees for the very poor. So these facilities have governing boards that include community representation, and this was mandated. So in about 93% of the facilities throughout the countries, hospitals and primary health care facilities, there is a governing board that includes community representation. In some places, they're also requiring that women's groups be represented, that there be a certain gender component, our friend isn't here yet, on these groups so that those populations are represented and those interests are represented. What has been some of the goals have been improving efficiency and faster decision making on investment and of course responsiveness to community needs. And there's lots of sort of anecdotal examples of facilities that improve their maternal wards or set up a more friendly or infection controlled patient waiting areas, things like that. And then some of the challenges, really, I just wanted to point out is that it was a concerted national effort, and so that takes investment, and there was a huge amount of training involved, both at the facility level in financial management, but also in how do you engage a community in a board in an environment where the culture is, in many cultures, in a government, it's basically the decision-making process was changing, and you needed to listen to the community, and how do you manage that process and those relationships and to become comfortable with that. So, and I would say, one of the success factors is indeed the political will that was behind it. In Senegal, we have basically a 2-year-old initiative that's been started, and it is, again, in the context of health finance reform, where the government is looking to decentralize, and in so doing, they are emphasizing mobilization at the community level, building on the history of mutuals in some regions, and building on basically with the objective of expanding community-based health insurance. So in that project, Abt is working with World Vision and Plan to mobilize community-based organizations, and our role is working with the local districts to set up contracting mechanisms. Again, building on what Joe said earlier, is paying these community-based organizations for their essential services, which is mobilizing the community, doing outreach, and ensuring that responsiveness. Some early successes, and again, this is the objective for USAID in this particular case is to create demand on behalf of the community. So demand for services, demand for responsiveness, frankly. And some of the early successes is that every quarter we're tracking and finding that there's been an increase in enrollment in community health insurance, which is a great start. And some of the challenges that we're foreseeing or expecting is ownership. So when something is so heavily donor funded, how is this going to evolve, and are the communities going to own their role in engaging, or the community-based organizations rather, own this role in engaging populations in their health care? I'm trying to think of the other challenge that we were identifying. Oh, and reducing the cost of health care. So again, there's a lot of donor funding behind these contracts for the community-based organizations, and so happily these challenges are being thought about now, and hopefully will result in some work towards sustainability towards the end of the project.
And now Eric from SAFE.
Good morning. Could I have? I've got only 2 slides, so I won't abuse. Hope everybody stays awake. So I kind of feel like the 2 panels and the team's talk really kind of build up to a lot of things. So one of the things that perplexes me is that even though we've had the romantic, apparently Alma-Ata period, and every woman, every child, and acting on the call, and all these things, in our day-to-day language in this field, there's still a little bit of a dichotomy between when we talk about health systems and when we talk about community health. And that kind of perplexes me. So 3 years ago, a core group organized an event with UNICEF, with PAHO, and with USAID, asking where is the sea of community in health system strengthening. It was really a lot of fun, and that was the beginning of my involvement in that with my MCSP colleagues, and I got to acknowledge Nazo Qureshi, who's here, and that led to really interesting discussions and a work group being formed and papers and etc. And then at the conference in Johannesburg last year, there was a model proposed that was called Beyond the Building Blocks. And I'm not going to spend a lot of time talking about the model, but I'm going to use it as a visual support to make some points. So if I can have the next slide, and that'll be the last slide. So I don't have a pointer, but don't be, we all know that a health system, and this one is an effort to say, how do we better integrate community health in health systems? That's a complex matter with a lot of variation, variety, self-organization. I was so delighted to hear Tim talk about that. But here what you have, and don't be, I don't like blocks, but we followed the logic of the building blocks because it's common parlance in our field. And if you talk to policymakers, ministries of health, financiers, people understand the building blocks. If you don't have human resources, nobody's going to do the job. If you don't have commodities, it's going to be a problem. So we follow that same logic. And in pink, you can probably rapidly recognize the traditional building blocks. And then in blue, I will speak about some of the ways we think they need to be amended. And again, this is a high-level model, so it doesn't tell you how to do any of these things. How to do these things is what we heard a little bit before. It tells you if you don't have these things at the high level in planning and in resourcing, then people that do the real work are going to be always fighting the tide to be able to do it. So the first thing we do, if you look at service delivery and health workforce, we've decided to break down the boxes a little bit and say, well, we now recognize that there are, depending on context and epidemiology and burden of disease, there are services that need and can be delivered at community level. And so you need a specific community health workforce to do that. And if you want them to deliver services of quality, they need to be trained, probably supervised. And if they're going to be part of a health system delivering services, the oversight probably needs to be from the technical agency, which is the Ministry of Health or some contracted partner. And probably if they work, maybe we have to pay them. So one common mistake of community health is to confuse cost effectiveness with cheap. And community health is expensive because of scale. It is just extremely cost effective. And so that's part of the dialogue we need to have. And there's a paper about the 11-to-1 return on investment, etc. So the argument could be made for commodities, the argument could be made for financing, the argument could be made for information systems, but we're trying to keep it a bit simple here. So that's the first point. We're just saying now we have got consensus and recognition that we need to think about that systemically. Then the next thing, if you slide a little bit to the middle and the right, well, the thing I forgot to say is if you're a duty bearer of health, your job is not just to run clinics, public health clinics or hospitals. Your job is to think and be accountable for the health of your population. So the top of our model looks at service delivery as being a key determinant, but other proximate determinants like household production of health and social determinants of health. And whereas, MCH, a division director in the ministry cannot be in charge of fixing all issues with social determinants of health. The governor, the duty bearer of health, has a responsibility to think through these issues. And this is kind of a high level, what are the things we need to think through? So that leads us to this additional blue box that's called community organizations. And it's a little perplexing. Why do you put a building block that would be community organizations? Well, I would venture that a lot of the panelist presentations, pretty much every one of them, talked about, well, I love the one that started with a group of friends getting together. As soon as you have a group of friends getting together, as soon as you have 3 women, as soon as you have 3 neighbors getting together, and you want to start organize that human capital to deliver a health benefit, you have a community organization. When you have a health committee, you have a community organization. When you have a women's group, a care group, a participatory women actions group, you have a community organization, especially if you want to leverage that capital to get health results. So it seems to me that community organizations are an essential part of it. And we've got examples. I mean, in Egypt, our programs in Egypt, we've had a very interesting way to work with community health workers on a national scale, 14,000 community health workers. And we have the example of working through community organization and without community organization. And actually, the bank is supporting a model that's kind of not parallel. I mean, it is two cadres of community health workers, some supported by community organization and some without. And there'll be some evaluations coming out, and I'm placing bets right now. At Save the Children, this community organization has been driven by the community action cycle and a number of things that have spun off, and it's been very interesting to see that. And we know that in our, rich countries, social support is a main predictor of when we're all going to, kick the bucket. So that's a fact. So if you want this impact, we need to think about not just the volunteers, but also instruments for the accountability and local governance we were just hearing about. So community organization seems to be very important. Then the next thing we have underneath, we're trying to get from confusing to obscure. We have societal partnerships. So societal partnership is a bit weird as language, but I think we heard about it this morning already. You can think about Ministry of Health being the governor of health, all right? But we already heard about, you have other sectors. How about education? Does education play a part in producing health? How about agriculture? How about livelihood, economic development? So the Ministry of Health is not in charge of running these things, but the Ministry of Health, the governors of health, and we, by extension, as supports and partners, need to be thinking of how do we leverage these things. And, as we expand in the role that we have. I mean, we're very excited to see, UNICEF and World Vision starting to, think about, brain development. I think there's a brown bag announced. We're going beyond survive to thrive, and we're going to have partners across sectors, but also actors. So civil society, I think the case has been made very strongly this morning. You need civil society. You need private sector. Hopefully, very often, non-profit private sector, because it's a little cheaper. And then there might be niche areas where you need a for-profit sector. I mean, I come from the private sector. And academia, research centers. And these are not outside of the health system. They are part of it. I mean, they can be contracting, they can be many ways. But certainly, as we're starting to talk about accountability and governance, we've heard about it, and we need it just for the sake of diversity. You can't have healthy governance of any sphere without diversity. The opposite of diversity is autocracy, and autocracy rarely leads to long sustainable outcomes. And in the governance of health, we heard it from Tim, it's messy, it's pluralistic, there's competition between goals. What are we going to do? We need that diversity. We need key populations to be part of that, and at many levels. So to have these voices, you need the societal partnerships. So we could give examples. Actually, some of them are on papers, on the tables outside. The work we did in Guinea, in Uganda, the faith-based organizations for HIV/AIDS care and treatment, ICCM in Rwanda. We've got an interesting papers about that. So I'm not going to repeat all of these. But then the last major point we have is accountability. And that's kind of a mainstay of today's topics. And we didn't create a box for accountability. And I think accountability is a bit like quality. Quality is about how you mix these different things to achieve quality. The examples from Lisa were here. Accountability is a little bit the same. Here we anchored it to information and learning. We could have anchored it, actually, we tried to make it close to the governance box because boxes are, suboptimal. We should have made it very close to the, societal partnerships. Accountability is about the how. And some examples come to mind, and we need that. If you don't have diversity, you don't have social accountability. If you don't have social accountability, your whole stream of accountability is probably weak. And then you've got, health systems that don't cater to the needs, only to some services. So examples that, come to mind is the class model of future generations in Peru. Maybe because I was a student of Carl Taylor and it was recently republished with updates. That's a very interesting private, non-profit model of building not only social accountability, but better financial administration and support to structures. For us at Save the Children, I think the big mainstay has been the partnership-defined quality, and I'm not going to start describing it, but that's been really a big mainstay of bringing data, bringing the diversity, bringing the communities, and building social accountability. Our friends at R40 are doing interesting models of evaluating investment in civil society organization and actually, kind of measuring what they're going to get out of it in terms of accountabilities. That's fascinating. And I would venture that in many cases, we've had a little bit in the green room discussion about international NGOs and local NGOs. In many cases, I would venture that groups like UNICEF, projects, NGO projects, be they larger, strong local organization or international, we actually play the part of these societal partners and help these things happen. And maybe we need to phase out, maybe other people need to take the spot, but that spot is not necessarily taken by the government. And there are two counterfactuals to this little kind of rapid picture about elements we should add to our model, is what about if we're in a country where the government thinks it can do everything? After all, these democratic, romantic ideals, that's kind of passé, I mean, we don't believe in that anymore. So what about countries? And I look at 2 African countries that were the only 2 African countries that were on the fast track to the 3 MDGs, Millennium Development Goals. And those were Rwanda and Ethiopia. And those are not countries where the government is weak and not showing leadership. Those are countries where there's very strong governance and leadership. However, I mentioned the sustainability of ICCM in Rwanda, for which there's a paper. At the same time, the same day, there was a publication by the Ministry of Health colleagues, and we actually worked together about the scale-up of ICCM. And I think it was very clear that the role of societal partners is very key in that case. And in the case of Ethiopia, at least you won't argue that there's anything less organized in terms of community organizations than a health development army. I mean, you can't do more organized than an army. So already that case is kind of supported, even in a country with strong government governance. The long term of this societal partnership, I think, is going to be beyond the scale of single evaluation. It's going to be societal trends we'll have to judge over time. But even in pastoralist areas in Ethiopia, the government welcomes societal partners. It needs them. So my conclusion, I've seen the sign. So the point of this is not to draw a picture and have a concept. The point is to say, if we're going to have this variety of mechanisms to do good community health that's well governed and that builds accountability of the system, responsiveness, then what happens upstream at the policymaker financing level is very important. And the hypothesis put forth by this model, and hopefully the paper will be forthcoming rapidly, the hypothesis is that if we are not explicit about adding some pieces like the specific health services at community level and the workforce, but also the community organizations, which is the way to build this capacity to hold local accountability, but also to mobilize volunteers, peers, women, etc., we're going to miss something. If we do not conceive of investments and policies as requiring societal partners for the national health system or systems for health, the way we like to talk about it at SAVE, we are going to keep having to reinvent it. And accountability needs to be integrated in these pieces. And that's kind of the pitch this model is trying to make for rethinking and expanding the building blocks models.
Okay. Thanks very much, Eric. Great. So we have a few minutes for questions. So we heard from Caroline about how over time effective community health systems can be developed even in very difficult environments and difficult areas. We heard from Lisa how about relatively short-term support can actually work with local stakeholders to build effective community health systems. And then from Eric about the big power, keeping the big picture in mind, but also some very nice examples from cross countries. So over to you. Any questions for anyone else? Ali. Oh, sorry. If you could say who you are and where you're from, thanks.
Hi, I'm Sam Rick with IntraHealth and the Frontline Health Workers Coalition. There's been a lot of talk today and a lot of other places about more engagement of the private sector in the health system and also about accountability, but there hasn't been much talk about accountability of that private sector, especially when we're talking about for-profit private sector. like who is profiting, who is benefiting, those kinds of questions in terms of especially a sector that hasn't historically been attentive to the needs of the most vulnerable. Wondering if any work is being done on that, a lot of attention played to that when we're talking about accountability, not just of government and of community, but of the private sector that we're looking to engage.
Thank you very much. We'll take a couple more questions. Ali, you had a question at the front here.
Okay, thanks. I think I have one question on the financing part, right? I think it has been maybe touched on in a different presentation, but it's just sort of like, again, this is probably coming from a specific experience that I'm working on. I mean, a lot more countries now are decentralized, right? Which means that there is a lot more of this intergovernmental fiscal transfers, right? And then the other thing is with the social health, you know, with the movement towards like the UAC, there's a lot of social health insurance as well, where there is a provider payment mechanism at the health facility. So again, from the sort of work that I've been working in several countries, there seems to be not very sort of strong sort of focus on how we can tap into that, right? Because especially a lot of this, you know, like for example, primary health care, so in many of these decentralized countries, they're actually a technical unit of a district government. So that means when there is a planning and budgeting process to, for example, prioritize spending for community health workers as being seen as an outreach beyond PHC. This is kind of a community-based PHC, for example, but how to kind of, we can raise that awareness so then they understand that this is, you know, this is not a separate CHW program or frontline program, but it's really part of the PHC, and then, so then, therefore, then they can allocate some more of this funding. That's from the intergovernmental fiscal transfer. The same with provider payment mechanism, right? We're kind of trying to have this policy sort of dialogue in Indonesia where there is now a strong, social health insurance. There is a provider payment mechanism to the primary health care, but they don't really seem to kind of, you know, sort of allocate enough for the, for example, for the community outreach, right? Where there's then a lot of this community health system really need a lot of support, and that leads to kind of a weak support from the PHC. So to me, I mean, it's from the financing point of view and the domestic resource, I think there's also this scope of, especially with the growing decentralization and the social health insurance movement in a lot of these countries, that's something that kind of, I'm just curious, like, what's your thinking on that front? Thanks.
Thanks. Vincent, yeah.
My name is Vicent Butera. I'm a graduate student at GW in Global Health. So to me, what I got from this whole conversation is that this seemed to be a very complicated system, but it also needs a lot of healthcare work, a lot of professional healthcare workers. And through my readings and through schoolwork, it seems that there is a lack of that. And what is Abt Associates and all the stakeholders involved today, what's being done to increase the number of professional healthcare workers? But not only that, the supporting system in terms of the social partnership. Are we also training epidemiologists, M&E workers from the global south, people who are living in these countries, to be able to contribute towards building this more effective healthcare system in these developing countries?
Thank you very much. We'll come back to the questions next, if that's okay. We'll take those three, then we'll come back to, we have two more questions over there. So back to the panel. We'll go reverse order again, if that's okay. Maybe Eric, you want to start? Just some brief responses.
Okay. I'll leave the private sector accountability to colleagues. It's a good question. In terms of, and I'm not sure I'll address the question right, but in terms of decentralization and social health insurance and things like this, and how to make the space for community outreach, I think that's one interesting piece where, and we didn't talk a lot about that today, but for example, in our project in Bangladesh, we have both like the social accountability, whether it's through scorecards or partnership-defined quality, and at the same time, the technical support to the decentralized health system and how do you use information and everything. And I think sometimes, especially in DC spheres, we can talk very conceptually. I think at decentralized levels, people can respond really operationally. And so, for example, in Egypt, maybe I mentioned that, but we worked with a very operational tools, like how much time are you going to dedicate for what services by which cadres of health workers, and what do you think it will achieve? And having, rather than have a list of policy and evidence-based services, having this kind of what do you expect to get, but what can you really get within time frame? We've got a little Excel tool. It was really fascinating to see how people started thinking of this, in real terms and started attaching numbers to it. And then for the number of CHWs, I think the effort to train more is very important. The effort to also rationalize and be efficient and not have one CHW, one task, and the effort to kind of make the difference between professional cadres and what can be done by volunteers. For example, Haiti wanted to get rid of volunteers at some point and only have professional cadres. It doesn't take a health economist to figure out this is not going to work, this is going to cost too much. So having some rational planning at the implementation levels, these decentralized levels, would be very important.
Thanks very much. Lisa?
I'll address, I think the first two questions I think I can address together. In terms of the accountability of the private health sector, just quickly, I think there is an increasing understanding that in many of these low and middle income countries, the private sector really does serve the poor. And if you look at DHS surveys and where people are getting family planning, for instance, there is a cadre of private sector like midwives and rural doctors where people do get care. And in terms of accountability, what I've seen is, for instance, in Indonesia, which was brought up as an example, Kenya, Ghana, and other places, the private sector, there is a goal and a strategy in many countries in the pursuit of universal health coverage to include private sector providers as access points for the basic package of services. But in order to be eligible, these private providers, for a payment from the government for offering these services, they have to meet a certain quality criteria, and that's often a link. So they have to, and in fact, our research supports this, that they may have to have a certain facility type, a certain type of provider that's located in the facility that has certain skills, et cetera. So there's a accreditation or registration process of some kind. And then in terms of decentralization and the Indonesia example, you're right, you point out a good point, and I've been to Indonesia recently and looked at this issue where the private sector is a little bit in some ways under a disadvantage because they're paid the same amount as the public sector for the same services, but they don't get the subsidy in terms of their cost of their facility being paid for and their salaries being paid for. So that's an issue, and I know that the government is seeking to address that, but there are sort of collaborative processes and dialogue happening around that. Abt with R4D actually we're in supporting the government in some implementation research around universal health coverage that is also addressing this challenge. And then in terms of community healthcare workers, and I have a couple colleagues here who may want to pipe in on I'm not familiar with every single project at Abt, but we do make efforts in terms of when we're looking at health finance reform. One of the issues is the payment of workers. Is if you're, for instance, in a place like Ukraine, if you're going to be a doctor, your official salary is barely subsistence level. And so how do you get people to join, to get into the medical profession? And a lot of that has to do with health finance reform and finding a way to afford to pay people a livable wage, accountability and transparency around healthcare workers. I think we've done some work in Haiti on looking at attendance, and if you look and you find the workers that don't actually exist, there's more budget to pay the people who are actually coming to work. So that's one of the things that we do.
Caroline.
Just to say that there certainly hasn't been enough work done in the Caribbean in terms of integrating accountability for non-profit healthcare delivery and also the social health insurance. It's begun, but it's not very far advanced, and it's an area that really needs a lot of work. About the numbers needed, I think one of the things, certainly from the Jamaica and the Caribbean experience, is that there's a lot that we pay people high salaries to do that doesn't need them to be paid, that doesn't need that amount of training and skill. And I come at it as a doctor. I mean, I'm a trained physician, but to talk effectively to an MSM who's not out, who's not going for testing, because if he was ever to walk into a clinic and talk about the fact that he's actually having anal sex, would mean he'd have to take a half an hour's Bible lesson before he got any further, or that doesn't require a 5-year medical degree or a 4-year or a 3-year. That needs somebody who has basic skills, which are very easy to acquire, that helps you to talk through and learn about voluntary counseling and testing, that helps you to engage that person in a conversation that's respectful, and that allows them then to go and change and determine better health-seeking behavior, better health prevention. So one of the things that we have got to move away from is the centralized collection of knowledge and skill. It doesn't have to be there. A better contact tracer is one that I trust, that I can tell who all I'm sleeping with, than the healthcare worker who I don't trust and who wrinkles their face every time I say, well, I had this man and then this woman. So I think one of the benefits of community system healthcare is that a lot of what we like to hold to ourselves as our skills as physicians actually belongs in the community and is better served by the community.
Thank you very much. I'm going to take 2 more questions at the back there. There's a lady and a gentleman, if that's okay, because we are close to the end.
Hi, good morning. I'm Gina Joseph from the George Washington University. I'm PhD candidate, Prevention Community Health. You listed quite a number of excellent community health models which have served effectively in your areas, and as I was listening to it, I felt that they can also be very applicable to other areas such as NCDs, and also the challenge with mosquito control that we are having in the Caribbean, particularly with Zika and chikungunya and dengue. And I was just wondering, have you developed any protocols to transfer that knowledge to those areas, or any other particular health area that really requires community involvement?
Thanks.
My name is Joe Piguez. I'm a non-executive director of AMREF Health Africa. I've worked in this sector for a number of years as a director and not as an implementator. I was also on the board of Save the Children for many years. And I've learned that the value of public-private partnerships are essential if we're going to continue to deepen the delivery of health services in low-income countries. There's no other way to do it in the face of declining multilateral and bilateral resources. What has been your experience collectively in forging partnerships to ensure the sustainability of local implementators of health programs at the community level?
Thanks. So there's a question here. Maybe one last question, and then we'll go back to the panel. It's okay. At the front here.
I'm actually tempting to not make a comment after your actually question is so broad that I think I'm going to abdicate my question. So there's more time for yours, George.
Thank you very much. And there'll be time after the session closes. Thank you very much for that. So maybe we start with Caroline for those last responses.
Absolutely. We need to take all the learnings and broaden them across all facets of the healthcare system. In our settings, I will echo Joe and I'll echo Lisa, political will, political will, political will. And it varies. The HIV response across the Caribbean and the integration of community into it, it varies immeasurably and very sadly. Some of the wealthiest countries in the region that have not been pushed in this direction by donor funders, by international development partners, and that can afford not to listen are actually showing the effects of non-integration now with really unbelievable problems of delivery of healthcare and backward sliding, even in HIV. So yes, we need to do that. There are models. These models are replicable for any community health system development and rollout. It's political will. Who's listening to you and who's taking you on? Public-private partnerships, I don't think that there's an NGO that exists or a CSO that exists without some even informal public-private partnership. Whether it is that your small community organization buys your coffee and tea from the shop on the corner, and the shop on the corner benefits from catering for your coffee and tea meetings, all the way up to a JASL level or a Guyana TransUnited level, where you are actively working with partners and forging partnerships with ministries, with private psychiatrists, with private healthcare deliverers to help deliver the services you want to deliver. How structured it is and how we ensure that that everybody is in a position to understand the importance of it, I'm not sure, at least for the Caribbean.
In terms of the first one of the transferring of knowledge, I'm going to just let what Carolyn said sit, because I agree 100% and don't have much to add to that. This is a really, the public-private partnerships for sustainability it's a difficult nut to crack, and that was something that, as I mentioned, even at the policy level, at the country level, there's still, it's an issue that is recognized as a challenge, but also a key for access and responsiveness and quality. I can name, there are a number of examples. I think Joe, with his experience working with the private sector, could probably even provide more. I can say that, what I've seen that works is to engaging the private sector in a way that it meets their interests, that their interest at the very start is recognized and addressed. And their interest is often in, they do want to provide quality services, but they also want to be able to operate profitably, to provide, to have a market, to understand how to provide the services at a financially sustainable way, things like that. But to be included, I think there's a little bit of stigma involved as well about the private sector at different levels, often among the public sector policymakers. But I think one example that I could show is linking. One challenge that private providers have is on investment. They don't have a government budget, which is a big piece of health financing in most countries. They don't have training provided to them. They don't have equipment provided to them. They have to do all of their upgrading themselves. One thing that I personally have worked on is linking private providers with commercial finance institutions and helping for instance, a local bank to understand what is a business model of a midwife clinic, and if you can, provide them with a small business loan, that will allow them to improve quality and expand their services and be an option for people in that community who can afford to pay. And often, particularly in the case, let's say the case of the Philippines, that allows them to upgrade so that they can participate in a health insurance scheme that the poor benefit from.
Eric. Just a word about translating all these experiences into other areas like Zika. So we've got an interesting project in the Latin American region, multi-country, that's run by the former Minister of Health of Peru, and that's because we've got this community action cycle culture, I think that's allowed to use technology and have very participatory community-based approaches to surveillance and response to the risk of Zika expansion. So that would be something I could plug you to. That's very interesting. On the public-private partnership, I'll just need 30 minutes to get into this. But with some slides, yeah, I've got 20 slides. And no, I think it's critical. I think there's a lot of examples, and I think we tend to do it well and think about it automatically at the very local level. I also think that even when there's reservations towards making public-private partnership happen, that's where our role as outsiders, you know, whether it's UN agencies, our agencies, you know, we come as outsiders and we allow things that don't always, you know, feel quite, you know, that people haven't embraced. And I think that's part of the logic and the rationale behind our arguing for a societal partnership block in the way the health system is constructed mentally to start changing these habits. I also think that there's not one private sector. There's many private sectors. You know, I mean, some people have simplified it as saying, well, there's a very informal private sector, and actually we work in Nepal to work with, like, you know, pharmacies and everything to work on, you know, a possible septic, you know, a severe bacterial infection of the newborn. There's also the private sector non-profit that can really has a mission and with whom I think there's a lot of constructive relationship that can be built. And then there's a very high-end for-profit private sector, and I'm not sure we really know. I mean, we've tried some things, not us personally, but I think it's a different nut to crack. So I think it's not one thing, public-private partnerships. And I'll cede the remainder of my time.
Thanks very much. Well, look, that's been great. We've come to the end of our time. In fact, we're a little bit over, so I am going to sort of end fairly quickly. I'd just like to sort of say, first of all, that I think the reason why we're here today and the reason why we had that big major conference last year, because I think that everyone's realising the central importance of community health systems. I think we heard from the panelists about this being, even though with this rising recognition, it's not easy and more effort's required. And it was good to hear not just the challenges, but also some great solutions and ideas about that are out there. But final word of thanks to the World Bank and UNICEF and USAID for helping us organise this, for our panellists, for your time, and also for the great questions from the audience, so thank you very much. And also for those behind the scenes that helped organise it. I call out Kate Green, Jen Leopold, Seika, actually all involved to make this event happen, so thank you very much.